Hello, everybody. Thank you for joining our third webinar about modern shockwave therapy. I give you a short introduction about myself in a minute. Let me just share my screen with you. Okie doke. I think you should see everything.
Yes.
Great. My name is Alex. I'm a physiotherapist from Augsburg in Germany, and I'm working with a shockwave quite a long time, almost 8 years now. I'm working with a lot of sports athletes in Germany. Was in charge for first league soccer team and ice hockey team at the moment, and do a lot of research stuff about what indications and how can we treat some pathologies. I want to give you a short introduction about what the theory behind shockwave therapy, modern shockwave theory basically is, because it's always important what the tool in your hands is actually doing. So we're talking about theory differences between radial and focused shockwave. You will see a lot of cases, and at the very end, we will have some time for answering questions. Let me say one thing about questions. We will have a lot of time for answering many questions, but I think it won't be enough time to answer all the questions. If it is like this, then don't worry, your questions will be answered. Just send an email after the webinar and I will answer all the questions you have during the webinar. When we talk about the theory of modern shockwave therapy, we need to say, what are our aims of modern shockwave? So first, we don't need no or less medication. We don't need no or less injections, for example, cortisone injections. We can avoid surgeries. It's non-invasive. We have a low risk level. And for this, a high effectiveness in our treatment. What at the very end of the day means we have got happy patients. And of course, we will have a successful clinic. What is the science behind all this? When we talk about science, we need to mention this guy. It's Professor Christoph Schmitz. He's full professor of University in Munich, actually for anatomy studies. And he is doing research about shockwave therapy more than 50 years now. So most of the studies you will see during this lecture now have been done by this guy. So almost everything what we know, how shockwave is working, what we can basically treat, he was involved in the research. One sentence about the Pedro database. It's a quite important database. In this database, you can find 54,000 randomized, more obviously by now, controlled studies. So evidence-based level 1 studies about a lot of things, how to treat and stuff. But a lot of studies about shockwave therapy can be found in this Pedro database. So whenever you look for basically an indication or an issue you're not quite sure about, can I treat this with shockwave? Is there any evidence about this? Go to Pedro database, check the database, and you will find important studies. One sentence about this: when you look for shockwave studies in the Pedro database, always check which device has been used. As you will see later, there are many differences on the market. So all the time check which device actually has been used for the study and which device is proven to cause the effect. We have some important conclusions about the Pedro database when we just check the whole database and all the shockwave studies we can find in this. 3, I will mention now. Basically, there is no general advantage for focused shockwave over radial shockwave. We come to this into detail a little bit later. Then it is wrong to call focused shockwave just high energy and radial just low energy shockwave treatment. And 75% of these RCTs about radio shockwave listed in the database were performed with a Swiss dollar plus device. What is the technology behind all this? As you can see on these pictures, what are shockwaves? Shockwaves are acoustic waves. And a shockwave is a kind of sonic pulse with physical characteristics which are really special for this kind of wave. So if you have a look at the picture, you can see we need a high rise of pressure up to 100 megapascal in total in a very short time, because then it followed this by a negative phase. We call it tensile phase, which is going into the negative area, up to 1/10 of the maximum pressure we can deliver in the tissue. So basically, the stimulation of the tissue by shockwave starts with a, call it compression phase, and followed by a negative pressure phase called tensile phase. In this tensile phase, the energy releases from the compression phase in the tissue. And one of the effects of this energy restitution is the generation of cavitation bubbles. So keep this in mind, cavitation is important to generate an effect in the tissue. A high cavitation level is a result of a high amount of energy density delivered by the shockwave device. So a lot of cavitation, high density of cavitation also means we've got a lot of energy density, a high energy density produced by our shockwave device. So let's talk about the radial shockwave first. Radial shockwaves are generated by compressed air, which is entering the piston, accelerating a projectile in the piston, which strikes the applicator with a very high speed, up to 90 kilometers per hour. And this kinetic energy is converted into acoustic pressure wave. And then, as you could see in the beginning, with the high pressure and low pressure, negative pressure, it's entering the tissue through the skin. So again, we've got the high pressure phase, the compression phase, up to 100 megapascal with the radial device. Looks like this in the picture. And we've got the negative phase where we create the cavitation bubbles, as you could see in the second. And I also have a nice video where you can see how the wave is leaving the applicator, and you can see the cavitation bubbles appearing in the tissue. On the other hand, we have the focused shockwave device. Focused shockwaves of the Swiss piezo class are created by synchronized expansion of these piezoelectric crystals. Everybody of you knows piezoelectric crystals. Everybody basically has one piezoelectric crystal very nearby at the moment. It's in your mobile phone. The vibrating of your mobile phone is generated by one piezoelectric crystal. In this handpiece, we've got 1,000 piezoelectric crystals, and the vibration is causing basically the pressure. So we've got a voltage supply, we've got the piezoceramic crystals, we've got a gel pad, which basically helps us defining where we have our focus, the midpoint focus. And the penetration is going up to 8 centimeters. So again, we have the same characteristics. We've got a high pressure phase up to 120, 140 megapascal. Compression phase looks like this. You see the difference, how the wave is leaving the tip in the applicator, which is larger, has a larger surface, followed by phase number 2, which is the tensile phase or negative phase, where we basically create our cavitation bubbles. And also here, I can show you the video, how the wave is leaving the tip. you can see how the focus is concentrating on a small area. And we see our cavitation bubbles. According to this is one of the most important studies about effect of shockwave or not. So I told you that the cavitation bubbles are really important. And by this study, we know that a significant part of the effect of shock waves in the tissue is mediated by cavitation. So we need these cavitation bubbles, which can be found in the negative phase of the wave. In this picture, you can see how the cavitation bubbles start to appear and enlarge during the wave phases. So we have the compression phase. In the compression phase, the bubble gets compressed and gets released in the negative phase. If one wave is over, we call it jet stream, the burst of these cavitation bubbles by the next wave and the next cavitation bubbles following. And this is basically causing the effect in the tissue. I told you before when we talked about the Petro database that it's quite important always to check which device is used. And I also told you that cavitation is a high amount of cavitation is a sign for high energy density. And by a comparison of different handpieces, you can see what actually is happening, how much cavitation can be produced. So if you have a look on the left picture, you can see we've got the same settings and 5 different handpieces. I leave out this device because as you can see, there's almost nothing happening. Yeah. So what you can see is in the middle, 3 different EMS handpieces. We can see the BTL handpiece in the beginning, and the last one is the Storz handpiece of the radial device. You can see that a high amount of cavitation bubbles, this one is not existing anymore. So we are basically talking about these two, and you can see a high amount of cavitation, a high density of cavitation. Now you could say that, yes, and BTL has some black and some black, it's not really less, so not really few. So we can also have a perfect effect with these devices. Let me show you what's happening if we just try to count all these single cavitation bubbles which is produced. And that's basically what Professor Schmitz and his colleagues did. They counted these cavitation bubbles because in the left picture we can't see how many bubbles are actually lying over each other. So we need to count them. And if you now compare how many, the higher amount of cavitation bubbles produced by the EMS device and in comparison to the Storz and the BTL device, you can see that almost nothing is happening in the tissue. So, and even if we go up to 5 bar with the 2 devices, which are able to increase the pressure input in the piston up to 5 bar, you can see that the cavitation is not really getting bigger. So the air pressure of these devices does not predict the energy output of these devices to the patient. Then we come to this study because about the energy output to our patients. This is one of the most important studies, has been done in 2022. What you can see on this picture is the dollar class device, the newest device on the market. Yeah. And you can see that the EMS device can maintain constant energy at almost all frequencies. Yeah. So we've got 4 different bar settings used in this graph to compare with the other ones. You can see 1 bar, 2 bar, 3 bar, and 4 bar. You can see the energy delivery to the tissue. And you can see the increasing frequency. Now you can see that the device can maintain the energy outcome at almost all frequencies. Just at the very end, highest settings, the EMS device is losing 18% of the maximum energy outcome. But if you check the Storz Master Pulse 200 Ultra, which was used in this study 2 years ago, you can see that if you check the 5 bar settings, which the Master Pulse is able to generate, you can see that just in the very beginning, we get a slight amount at 1 Hertz frequency of energy delivery to the tissue. If we now increase the frequency, the energy delivery to the tissue drops up to 92% of the energy outcome is just lost. Now I told you that 90% of the studies done with the dollar class shockwave published on the Petra database used an energy flux density which is 0.1 millijoule per square millimeters or higher. And with this energy flux density, clinical outcomes demonstrated with the dollar class device can't be claimed by other devices. So we know we need 0.1 millijoule per square millimeters, which are used in 90% of these studies. And if we now draw a line at the 0.1 mark, you can see the Stolz device is just not able to even reach the minimum energy flux density which was necessary to generate an effect in 90% of these studies. This is just possible with the dollar class device. A second. So now everybody could say, okay, if I don't reach enough energy with my device, I just increase the pulses, double the pulses, triple the pulses to get more energy in the tissue. Yes, the idea behind this is quite interesting, but it's unfortunately not working. Yeah? So the lower energy outcome cannot be compensated by increasing the total amount of impulses, which is proven in a study which you can see here. And also the conclusion in this study is high energetic radio shock wave, so up to 0.24 millijoule per square millimeters in comparison to the low energetic radio shock wave, so 0.12 millijoule per square millimeter, is leading to better therapy results. So we know we need as much energy in the tissue. So we need a lot of cavitation to generate a high energy density to get better effects and good therapy results. And this can't be compensated by just doubling the amount of impulses. I want to show you two just comparison videos about two devices compared with an EMS device, where you can see basically how cavitation looks like and how it doesn't look like. I put both for the same time. Hang on. Sorry, video viewer just had a problem. So now again. The EMS device on the right, and the left video is on the left. Basically, what you can see the differences. Now let's talk about the same thing with the focus devices. Yeah? This is a very previous study from 2018, open access 2013. What you can see is the Swiss piezo cluster, the focus device of EMS, reaches in the compression phase up to 115 megapascal of pressure of energy. And what you can see here is minus 20 megapascal in the negative in the tensile phase. Compare this with the stored Stuhlith you can see that this device is just generating about 42 megapascal of pressure. So 1/10 about, it's less than 10 minus 10 megapascal of pressure in the negative in the tensile phase. And if you remember that we need a large tensile phase to create a lot of cavitation bubbles to generate a lot of energy density in the tissue, with these two graphs, you already have the proof that it's almost not possible. Another interesting side information for you is that the only device worldwide which basically can produce a proper, real shock wave is the piezoclast. The stored stoolith is not able to produce a proper shock wave. To make this device producing a proper shock wave, you need to double the pressure, and you have to put the device into water. That's the only effect where you can, in the highest settings, where you can generate a focused shock wave. So again, 2 times higher pressure. That's therefore higher amount of cavitation bubbles, higher energy flux density in the tissue, better result. Comparison of maximum energy outputs. We have got the radial device, which is going up to 0.28 millijoule per square millimeter, and we've got 0.55 millijoule per square millimeter for the focus device. Penetration is a difference between these two devices, up to 4 centimeters with the radial device, up to 8 centimeters with the focus device. The radial device is the most versatile device, so it's good for superficial applications. 90% of all tendons are less than 15 millimeters under the skin. It's good for treating larger surfaces, so large muscles, muscle chains. Faster treatment times, up to 3 times faster than the focused shockwave treatments. Why choose the focused shockwave then? We need it for deep applications, for high energy applications, so for bone bruises, delayed fracture healings, for example, for precise targeting, and for hypersensitive patients. What are the effects of shockwave therapy? We get an immediate pain relief or elimination. This is one of the effects which the patient can feel during the treatment. We have an increase of blood circulation in the entire surrounding tissue, inhibition of inflammation, activation of reparative processes in the tissue, and a muscle relaxing effect. Let's talk about these. So, to talk about the pain and everything which and the healing, we need to talk about one basic information, and it's called neurogenic inflammation. Neurogenic inflammation and substance P, which is important for the pain feeling, what we have, are working together. They are kind of self-stimulating mechanism. So we know that substance P increases the sensitivity of C nerve fibers, leading to an increase of nociceptive signaling, so pain. This pain stimuli trigger a protective response and releasing more substance P by the C nerve fibers. And this substance P stimulates the activation of mast cells, leading to a release of histamine and vasodilatation, so neurogenic inflammation. This neurogenic inflammation is increasing the sensitivity of C nerve fibers again. So we have got a self-stimulating mechanism. We need to get rid of neurogenic inflammation in the tissue first, otherwise we can't produce proper healing. And we also know that scleraxis is a transcription factor which is required for proper embryonic development of tendons and is released in this signaling. So shock waves inhibit the release of substance P by blocking the neurogenic inflammation. To make this very complex mechanism a bit more simple, and also to explain it to our patients, because they need to feel some pain, I always use a nice little example, which you will see in a minute. So first, Local anesthetics inhibit healing. Corticoids inhibit healing. These things, local anesthetics and corticoid injections, are just symptomatic treatments. None of them can inhibit the release of substance P, and none of them can suppress the neurogenic inflammation. So they can't induce proper healing because they're just symptomatic treatments. So I explain my patients, and it's in a physical way, it's in a physiology way, it's correct. Do it like this. Whenever you receive or get a shockwave therapy, it's like eating a red hot chili pepper. A red hot chili pepper is burning in our mouth. This is because of capsaicin. They are also stimulating the C nerve fibers, which are responsible for transmitting pain. But after a certain amount of time, these pain receptors get incapable of taking the transmitter, and your mouth is getting numb. So first, your mouth is burning, and then it goes numb. It's exactly the same thing what the shockwave is doing. Same C nerve fibers. Yeah, we are releasing substance P in the tissue and the spinal cord. This substance is causing discomfort, which we can generate during our shockwave therapy. Then, by this prolonged activation of these C nerve fibers, they become incapable of releasing substance P and causing pain. Think back to the pain circle. If the pain is going down, also the neurogenic inflammation must go down. So first we have pain, and then we can get recovery. And this is why our patients need to feel pain. If they don't feel pain, we don't get a release of substance P, and we have no effect on the neurogenic inflammation. So less substance P, pain is going down. If we have less substance P, the neurogenic inflammation is going down. And now, if this neurogenic inflammation is gone, is going down, then we get the release of growth factors, the activation of stem cells in the treated tissue, the increase of scleraxis for tendon repair. And then, basically, we get the proper healing. Scleraxis, very important, can be found in every stage of tendon and ligament development. So cortisons, painkillers, local anesthetics, they are all decreasing scleraxis. Whereas shockwave therapy is increasing scleraxis. And as a little side information also, isometric training is increasing scleraxis too. So with your epicondylitis patients, yeah, not always thinking of doing stretching exercises. Isometric exercises are much more helpful in these cases, especially in combination with shockwave therapy. So, what are our effects? Just for short remembering everything. We get a increased release of substance P. So we get analgesia, reduction of neurogenic inflammation, increase of blood flow. Then the release of growth factors and activation of stem cells, activation of cellular defense, and activation of the body's own repair mechanisms, like sprouting local nerve receptors, neovascularization, angiogenesis, stimulation of fibroblasts. Inhibition of COX-2, so we get a slight antiphlogistic effect, and of course, the muscle relaxation. What are our indications for shockwave therapy? Basically, I already mentioned everything what you need to know about indications. So when you know the effects of shockwave, and you can define indications basically for yourself. But of course, we have got some different indications. We have got the classics, everybody knows them. We have approved indications, approved by the company, so written in the handbook. We have got off-label use. They are not written in the handbook. We're talking about trigger points and more. Let's start with the classics. Everybody knows them, like calcifying shoulder, Achilles tendinopathy, tennis elbow, heel spur, or tendinopathies of the patella tendon. They're the commons. Everybody is using them for years. These are the approved indications for the Swiss doloplast, as they are written in the handbook, basically. So we see trigger points, we see, of course, calcifying shoulder and tendinitis, tendinopathy is different, Osgood-Schlatter disease, kinds of wound management, cellulitis, ED, idiopathic lower back pain, lymphedema, so a lot. I call these the modern indications or off-label use. So this is just a slight overview about what I treat in my clinic. When you look at these different kind of indications like sacroiliitis, for example, or fractures or bone bruises, all of these things, they have pain. Because of the pain, they always have a neurogenic inflammation. And this is what I know, what we need to get rid of. And then, of course, we need to get the body's own repair mechanisms activated to start the proper healing. That's basically the thinking behind these off-label uses. Trigger points. Why do trigger points work perfectly by using shockwave? We know that most of these trigger points just start to exist by a chronic overuse. If you have a closer look at these trigger points, you can see that we have a biochemical milieu in this area with selected inflammatory mediators. And we had this before when we talked about the pain and neurogenic inflammation circle. So we find similar inflammatory mediators in the tissue, which basically keep these trigger point alive. So whenever we have pain, the inflammation is going up, the pain is going up, inflammation is going up. So it's a self-stimulating mechanisms also in these trigger points. So it works perfectly to decrease the pain and the inflammation in these trigger points. It's a very short and effective treatment. We don't need to press these points for a longer time. And basically, it's the same thing what we do. We press and get a lot of pain relief, substance P, to decrease the neurogenic inflammation. By using the shockwave, 300-400 impulses on each trigger point are sufficient, high enough, and we can feel it's immediately popping up. Shockwave, never together with a local anesthesia. It comes at this part because a lot of doctors, therapists using local anesthesia, local anesthetics for trigger point treatments. We had this before already when we talked about the effect. Local anesthetics are just a local symptomatic treatment. They can't induce healing. They have no effect on the neurogenic inflammation. And another effect is, I told you before that shockwave therapy needs to be painful. So if I use local anesthetics, there's just no pain feeling in the area which I want to treat. So I get no release of substance P and no effect on the neurogenic inflammation. These pictures just show a way how you can treat the trigger points. So of course, number one treatment is for me using the shockwave device on these trigger points. Afterwards, nice to use some kind of cooling therapy. If these trigger points are just too painful, I combine them by using the high power laser before 5-minute program on these trigger points to decrease the pain in this area. Because high energy laser is working like local anesthetic, not like local anesthetics, it's working like ibuprofen. So I'm just changing the pain's threshold and not shutting down the pain receptors. And then I can apply the shockwave. And some exercises for trigger point treatments for the patient at home. To get more indications and to prove why my indications are working and why these indications can be used very effectively in your clinic, shockwave therapy activates the luprizine genetic expression. Luprizine can be found around each tendon, every tendon in our tissue, which is important for tendon gliding. So by increasing the activation and genetic expression of luprecin, we can increase tendon gliding in the tissue. So we all know these patients in our clinic walking, wearing a walker for 4 to 6 weeks, and then they get these walker removed, and then they have almost no ability to move the ankle, for example. Yeah, using shockwave is very efficient to increase the mobility of these ankles in a very quick way. We can improve blood supply. So by repeated application, we can accelerate wound healing and also start the forming of new capillaries in the tissue, which definitely takes a bit longer in time, but think about diabetic legs and ulcus disease and all these things where basically new capillaries are very important. Yeah, this study also with functional angiogenesis also is keep it in mind for ED, erectile dysfunction. Yeah, we need more capillaries in the tissue to get an increase of blood flow. So this is the proof. One of my favorite topics, we talk about new bone formation. So application of shockwaves for new bone formation begin with 0.5 millijoule energy flux density and increasing with the 0.9 millijoule. Yeah, so we know that we can induce new bone formation. And also for osteoporosis, always think about the device. It's an acoustic wave. It's not a mechanical wave. So even for osteoporosis, we don't get an increased fracture risk. Yeah, in this area, it's a good indication. We can't cure osteoporosis, but it gives a positive effect on these patients. They are really suffering. This study is the reason why we don't stop using the shockwave after 6 weeks of primary bone healing. We know that the proliferation and differentiation of osteoblasts is increasing. They have a dose-dependent stimulatory effect. So what I basically want is after primary fracture healing, after 6 weeks, we need to get the bone even stronger. So we still use the device not every week, but every 2 to 4 weeks, just to give a slight impact on the bone to still stimulate the proliferation in the tissue. Osteoarthritis of the knee. This meta-analysis results revealed an overall significant effect favoring shockwave as a treatment. So one of the studies showing osteoarthritis of the knee perfect. If you think about why, these patients have pain and neurogenic inflammation. So they need to get rid of pain and neurogenic inflammation to get the knee moving properly again. Also a very interesting study about the same topic, just to show you again, higher density is more effective in the knee. Shockwave after ACL reconstruction. So they improved after 24-month follow-up study more the patients who received radial shockwave during the rehabilitation after hamstring autograft ACL reconstruction. That's why we start this immediately. Patellar tendinopathy, we know that it is working. It's used, the focus devices are used for 15 years on patellar tendinopathies. Then they did a study about focused or radial. Do we always really need the concentration of these shockwaves on the tissue? No, we don't need it. These tendinopathies, it's very superficial indications, can be treated with a radial device perfectly. Patellar tendinopathy. Extracorporeal shockwave therapy has a very positive effect on patellar tendinopathy in athletes. Tendon healing after rotator cuff repair. Shockwave and exercises are more effectively by reducing shoulder pain, mobility, etc. after a supraspinatus rupture. Osteochondritis of the talus. Local shockwave therapy was safe and effective in patients with osteochondritis in the talus. Shoulder impingement syndrome, shockwave versus cortisone. It's a very interesting thing. I just chose the shoulder impingement to explain also the local anesthetics part with the triggers, with the trigger points. Yeah. Cortisone is a very quick responding effect in the tissue. So cortisone just shuts down all the pain in the area. So it's very quick and effective working in getting the patients pain-free. But in a long-term view, if the cortisone effect is leaving, the inflammation is coming more and more out again. So we know that the cortisone has a very quick, effective pain release in the tissue, but in a long-term view, shockwave is more effective than cortisone. Frozen shoulder. Compared to control groups, we can see significant clinical and statistical improvements in all outcome measures, which is just a brilliant way to treat these patients who are really suffering. Tenosynovitis of the long biceps tendon is something I see in my clinic almost every day. So shockwave is a very good way to treat these tendinopathies. Osteochondral lesions. It was a comparison study about shockwave and hyaluronic acid. And we can see that shockwave is safe, of course, and more effective than hyaluronic acid. And you don't have to do an injection. You don't have to penetrate the skin, which always tries to secure our joints and our body. But also we need to talk about contraindications about shockwave. These contraindications are written in the EMS handbook. So it's always, we always need to check if these contraindications are just a safety measure for the company, if it's a real absolute contraindication, and we need to understand why it is a contraindication. So we will go through these points. I will tell you whether it is, for me, an absolute contraindication, or if it is a relative contraindication, why it is a contraindication. So treatment over air-filled tissue. Company wrote this contraindication in the handbook because nobody knows actually what is happening in the tissue. If you think about the penetration of the radial device, which is going up to 4 centimeters, it's in most patients most unlikely to reach lung tissue. So treating the upper back is no problem at all. If you're not quite sure how many centimeters you can go, you can go deep in these tissue areas, there is a little information for you how you know that you're probably irritating the skin around lung tissue. I always tell my patients, when you feel a slight discomfort or you need to cough during the treatment, tell me and we go to another spot, because then we are irritating the skin around the lung tissue. We're not leaving because we destroy it. We're just leaving because it's uncomfortable in this area. And we can get a reaction from the phrenical nerve in this area. And then these patients start to cough. Basically, the radial device is not strong enough to destroy lung tissue, but the coughing effect is a good indication for you if you should go to another spot. Treatment of torn tendons. If more than 50% are injured, the reason for this contraindication is a law indication, a lower contraindication, because if you have a tendon rupture with more than 50% injury, and you're doing a shockwave treatment there, and after your treatment, your patient is doing a strange movement and has a full tendon rupture after this movement, it was always the shockwave therapy at the end which caused the tendon rupture. So this is the basic problem. If we are less than 50%, we know that the risk is just too low, that these movements can cause any worse injuries. Treatment of pregnant women. Of course, never treat pregnant women in the lower back or in the area where the baby is. This is an absolute contraindication. But why not treating pregnant women at a heel spur or carpal tunnel syndrome? Of course, we need to discuss this with the woman, but basically the wave is not entering the heel and ending up in the lower spine. We're talking about a penetration of 4 centimeters. Treatment of persons under the age of 18. Exception, treatment of Schlatter disease. This is an anatomic issue why we have this contraindication. We don't want to shoot or give energy at the growing zones of children. So epiphysis is a absolute contraindication because nobody knows what is happening in these areas, in the growing zones. Schlatter disease, for example, tuberositas in the tibial bone is not an epiphysis, it's an apophysis. So this structure has nothing to do with the growing of these children. So we need, by application, you will see this during the cases, we can of course treat the apophysis without hitting the growing zone. When you can maintain for Sever disease, this was in my off-label use list, as long as you don't hit the growing zones. Sever disease is an apophysitis. So we have an apophysis again. It's the same with the Schlatter disease. So of course I can treat the apophysis. It's just, you need to know an off-label treatment because it's not approved by the company. Treatment of patients with blood coagulation disorders, like local thrombosis, of course, it's like all other manual or treatments we do in these areas. Yeah, with local thrombosis, we don't do shockwave there. Oral anticoagulants, it's a contraindication. If this patient needs shockwave therapy, we need to talk to the doctor if there's a way to change the medics, or if we can make a 1-week break for treating with the shockwave. So this is just something we need to discuss with the doctor. Treatment of tissues with local tumors or local bacterial or viral infections, of course, like all the other things we do. Treatment of patients who have been treated locally with cortisone. And this is, for me, one of the most important contraindications. Yeah, the minimum interval should be 6 weeks after the last cortisone injection. Cortisone is a cell poison. So if somebody is injecting cortisone at a tendon, we know that there are tendon cells, the tendon cells will be destroyed in this area. So we don't do shockwave in this area to avoid greater injuries. We're just talking about cortisone, local cortisone injections. So if you take a pill like systemic cortisone, this is not a contraindication. We're talking about local tendon injection. So now we come to some cases that you just can see how I use these things I just mentioned, and then we come to question and answers. So one of my most important indications, most of my clients have this is muscle injury. So I don't care if it's a muscle strain, fiber rupture, or bundle tear. We have a brilliant study a colleague of mine did with his second league soccer team. So he treated all the muscle injuries during one season just with using the shockwave device. And you can see that the layoff time reduction is up to 54% with different stages of muscle injuries. This was one of my first league players, and you can see what is basically happening within 10 days using the shockwave device in the muscle tissue. And this was one of my first muscle injuries. He's still playing, so that's why he's still in the lecture. Everybody knows how these injuries happen. A sudden pain attack during a sprint, for example, like in this case, you can see a big muscle injury, a lot of fluid around the tissue. Immediate treatment with price and some good compression therapy. Then we start in this case 24 hours after the injury. We try even to start within 12 hours with the first shockwave therapy, reduce swelling, reduce pain. Please don't write down all the pressure or numbers about impulses and frequencies. This is just the individual setting. I will tell you later at the end the main setting, how you can start every treatment. Then we continued the treatment for 14 days. It was completely pain-free after 3 days. We could increase to cycling after 7 days, to 13 days running. And this is the way we always increase the load depending of the pain reaction. So whenever something is pain-free, he's allowed to do it. Total downtime in this case, 35 days until able to play 90 minutes first league. But also prevention of muscle injuries. It's even more important than treating the muscle injuries itself. So you don't need 2 devices. This was just one of my apprentices, but we have statistics about severe muscle injuries. So highest level of muscle injuries of top 4 youth teams we had in 2014 until first half of 2016. And you can see we had a high amount of severe muscle injuries. Then in May 2016, we started to treat all players coming with problems in their muscles, like cramping, they got kicked, or did a strange movement, or just feel tired. So we treated all these muscle things with the radial device, and you can see how the number of severe muscle injuries just vanished. Fractures. Jones fracture of one of my players. You see, first day is always the same thing. Cooling, manual lymphatic drainage after surgery. Then quick start with shockwave therapy for increase of lymphatic drainage, for getting the area pain-free, reduce the swelling, and induce healing. After 4 weeks, we did a control X-ray. You can see that these really bad healing areas already started. So we allowed this guy to use to go on the bike and start cycling already after 4 weeks. What we do, or at the moment we prefer, is just to let them walk in our Alter G anti-gravity treadmill. Then if you check the control after 6 weeks, you can see it's even going further. So I'm not worried that this Jones fracture is not healing anymore. After 11 weeks, first season game, after 13 weeks, and then we continue doing the shockwave to get this area really tight. Fresh hand fracture, mid-hand fracture, no problem at all, full contact shockwave. Or more severe, complicated ankle trauma. One of a good friend of mine, accident during a soccer training, tibial fracture, syndesmosis rupture, front and rear, all the ligaments, horrible injury. Surgery, the accident happened on the 5th of May. 5 days later, he came for the first treatment. That was basically what the foot looked like. 2 days later, he came for another treatment. You can see how the foot changed. And this was another 3 days later, the result of the foot. So you see within 5 days, increased reduction of swelling, pain relief, and then we really induce the healing process in the tissue. These are just the studies showing us that even for delayed bone healing or non-unions, the radial device and the focal device are perfect. Delayed fracture healing, just a short example. After 6 weeks, this female hockey goalkeeper came to my clinic with these pictures. She was sent from a doctor for shockwave therapy. You can see almost no fracture healing in this area. You can see that in this area, it's already going to the inside. So we expected a real non-union can appear within the next weeks. So we started to do a combination therapy. This case's combination is very good to concentrate the energy on the superficial areas and also on deep areas focused on the bone tissue. You can see finally already a lot of colors appearing. You can see starting bone healing in this area already. We did another 5 combination therapies to induce the healing even more. And this is basically what's the result after less than 3 months of treatment. Or if it's a real pseudarthrosis, like with this guy, almost the same surgery, same accident the other player had, just the fibular fracture. And you can see 8 months after surgery that this is not healing itself. So 2 possibilities: doing shockwave intense combination radial and focused shockwave therapy, or another surgery. So we decided to try the combination because it was a really hard decision with this picture. But at least after 10 treatments within 4 months, we can see a fully healed cortical bone. Inflammation of the pubic bone was one of our tennis players. You can see the highly inflamed pubic bone area here. Also here in this area already is fluid inside. So immediate start with the radial device. Their first treatment with 1.3 bar, which is very low. Then a lot of physiotherapy, working with the lower spine and back and everything. And the result, after just a few weeks, we can increase up to the 3.6 bar on the pubic bone. Pain-free tennis player. We could increase the load pain-free. And after 8 weeks of treatment, we did the check and he already could play one of the first matches and one ATP point. We can, of course, still see the reaction in the pubic bone, but I'm not treating the picture, the MRI picture. I'm treating the guy. So as long as we don't get an increase of pain, we don't get an increase of neurogenic inflammation. This is basically our healing process. So if this patient has no pain, or not increasing pain, he gets not more neurogenic inflammation. And so we're still in the area of healing. Ligament rupture. I want to show you the ligament ruptures, especially by reducing the swelling. So basically, we are very quick in reducing swelling, reducing pain, increasing load, full tape, of course, with the professionals. And so that's why we can generate total downtimes of 19 days or 15 days or whatever. So this is just, of course, we get an immediate reduction of swelling, pain relief, and induce the healing. Same process to get them quick on the pitch. On these pictures, you can see what is basically happening before and after, or basically during one treatment on the left side. This ankle appeared for a lecture in my clinic to be a patient that I want to show how we can reduce the swelling. This was before the treatment, and it was after the treatment. So 20 people could just watch how we can decrease the swelling. What I like to do sometimes is to show my patients these thermography pictures to see what is actually happening after shockwave. So this was an ACL rupture, very, very hot leg. And this was the picture after the shockwave. Of course, the cooling in this area comes because of gel and of transportation, of course, but the most important thing is you can see that how the blood vessels start to get activated. Another picture just to prove it a bit more. Also here you can see more active blood vessels, and you can even see them how they start to work. This left picture here is a thermography picture after 30 minutes of manual lymphatic drainage, how an ACL leg looks like. And this is exactly the same knee after the shockwave therapy. So you can see the effect, the improved effect of shockwave in comparison to manual lymphatic drainage. And it's a long-lasting effect. So you can see here, this was some days later. He came 2 days later, and you can still see the blood vessels are working. And this is how it looks like after another therapy. Short wake up. The Schlatter disease. This, just want to show you the pictures. This is a way how to treat the Schlatter disease without hitting the growing zone, which is in this area. So a 90-degree angle on the tuberositas is sufficient to avoid epiphysis and just shoot at the apophysis. Opportunity using the high power laser before, if it's just too painful for the child, and using a cooling device afterwards. And after total treatment number of 3, most of these patients, these little small patients, are pain-free and can start training again. Always the load needs to be as high that we don't increase the pain again, because then we increase the neurogenic inflammation again. Bursitis capsulitis. This was an elbow spur which caused bursitis in the elbow. Treatment, result after 4 treatments, no pain, proper healing, no swelling, full range of motion. Frozen shoulder, as an example, how we can improve the pressure and range of motion. It's 2-month treatment. We started initially with 1.5 bar, very painful, could increase up to 3. Range of motion, a lot better. Pain reduction, pain a lot better. Everyday life without trouble. So we know frozen shoulder is going away anyway, but until this will happen, these patients need to be pain-free, and we need to improve their range of motions for daily activities. Open wounds, Taylor's toe, using plastic foil around the wound, some disinfection fluid underneath, and gel over the plastic foil, applicating the shockwave. And you can see a nice improvement, nice healing of the wound. But the most important thing is what is basically happening in the tissue. We get soft tissue. So with these wound management stuff, you need to think about all your scar tissue patients, not just after ACL reconstruction, but all scar tissue patients. So we need to get smooth and soft scar tissue to get full range of motion, good mobility, and don't cause further problems. Or even if it looks like this for scar tissue. Yeah. This guy came from the clinic because he gets an inflammation in this area and was supposed to become a bad healing wound. So 14 days after trauma, we started to do the shockwave, and the result after another 16 days was this: soft scar tissue, full flexibility in all directions, no pain, and a patient who can do running, cycling, and all these things. Chronic polyarthritis, 16-year-old patient suffering from this almost 28 years now, using painkillers. The hand looked like this in the beginning, on the first treatment when she came. You see the swelling in the joints, you see the color of the skin. She's not even able to open the fingers properly. This was the result after the second treatment, and this was the result after 5 treatments within 15 days. Just the study for unspecific chronic low back pain. Yes, of course. If I have chronic unspecific low back pain, go for it. If it's getting more complicated, I will show you something now. We're talking about kinetic chain treatments. This is very special. So far, we were treating just indications always on the spots where we have the problems. I will show you something different. We're talking about tendinopathies of the psoas muscle. We can't reach the psoas muscle itself because it's an under airfilled tissue. But I have a possibility to increase strength and power of iliopsoas muscle, treating sacroiliac joint on the right, left, small gluteal area until trochanteric region. The second thing to treat low back pain or dysfunctional biceps femoris, which is basically this case the same. So he was always, this young player was always suffering from low back pain. By doing electromyography, we could see that the left biceps femoris muscle was always activated while just standing on both feet. And this is what we basically did. Concentrate with the shockwave on the neck area, rhomboid trapezius muscle, just quick 5,000 impulses, the whole area. Yeah, and you will see an immediate effect. You can see in this case, the left biceps femoris muscle tension was even normal, which was surprising everyone. But the most impressive way to treat is this, and the most easiest way. This was one of my hockey goalkeepers. After hip impingement surgery, you can see extra rotation on the left is worse than on the right side. Very painful, 7 out of 10. And what he told us where the pain is going is lower back, trochanteric region, IT band, front of the thigh. So basically what all our low back pain patients tell us. And if you check the extra rotation, as long as possible, you will see the difference. But if you have low back pain patients, we expect the side where the pain is the worst extra rotation side. So what we do is, by influencing the flexor tibialis posterior muscle chain, kinetic chain, via different kinds of muscles, it's a bit more because it's also going up, but just to reach the iliopsoas muscle again, which is one of the most important muscles for all low back pain things. We're just treating underneath the malleolus medialis. Just 3,000 impulses, 20 hertz frequency, pain threshold of the patient. It needs to be painful too in this area. If you don't believe, just make a short change on the other side, and you will see that there is a difference in pain feeling. And the result after the treatment is this. So this is what our patients see and feel immediately. Range of motion is better, and therefore mobility is better. And most important, the pain score, even with better range of motion, is less. A very important thing for me personally is network. That's basically why I'm doing these lectures, to share knowledge, to come together. I also want to get a lot of information. We are a nice group already. This is just a German group, a lot of team doctors and physios and sharing a lot of these cases, but we are spread around all over the world. We want to get connected. Easiest way to get connected or to appear on the map is register your practice or your clinic, share your knowledge, ask questions, write emails, whatever you need to know, check the databases we have on the EMS website, the YouTube channels and Petro database, yeah, to get even more connected with us. At the end, your athletes or your patients will be very happy about it. So is our ice hockey club. Always think about what Ovid already told us more than 2000 years ago. To recover, you need to suffer pain. And this is basically what we do with the shockwave. I will close the presentation now and we switch over to the live view. And then please use, feel free feel free to ask your questions. So here I am. Just type them in the F&A. There are no questions. I tell you the treatment protocol at the end. Meanwhile, probably you get one question. So I promised you to tell you that there is just one treatment protocol. Frequency between 20 and 25 Hertz, because a lot of energy in the tissue, high energy in the tissue. Impulses between 3 and 5,000. If you have a really big leg to treat, of course, it's more. A good experience for me is how many impulses do we do until your patient feels better during the treatment, basically. So 3 to 5,000 is a very, very good number. Pressure, how much pressure do we use? Until we reach the individual pain threshold of our patient. We need this pain, neurogenic inflammation. Which tip applicator do we use? Large applicator, larger areas, small applicators, smaller areas first. Or as long as you reach the individual pain threshold of your patient, you can use whatever you want. So if you treat with a large applicator the area and you reach the patient's pain threshold, go for it. If you're reaching 4 bar and your patient is not feeling pain, you need to decrease the diameter of the tip to concentrate more power on a smaller surface. I see some questions popping in. Where can I learn protocols for the various injury areas? For example, frozen shoulder. What I didn't mention so far is how many treatments do we need and what period of time do we treat. So the settings, as I said before, for each treatment, we treat once a week, which is good. Also can treat more often, but basically once a week is sufficient. And 3 to 5 times in total. This is a rough number for all the indications we have. Just make sure if a treatment is not working or you have not a really good outcome, or you're doubting that anything is not running the way you like, think about the pain threshold. This is one of the biggest mistakes, that we always try to be too kind to our patients. they need to suffer pain a bit. 6, 7 out of 10 is the number I always tell my patients. And then it's working. Yeah. So protocol once a week, 3 to 5 treatments, 20 to 25 hertz frequency, 3 to 5,000 impulses, pain threshold of the patient. Michelle, is it okay to shockwave after rotator cuff surgery? It's definitely an off-label treatment. Yeah. What I would definitely do, use the radial device for pain relief and reduce swelling and everything. Yeah. Don't concentrate too much energy on the anchor, metal anchor, not because metal is a contraindication, but it's a very, very specific thing. So for pain reduction, reduction of swelling, perfect. Don't go on the anchor. Yeah, that's it. Metal implants are not a contraindication. It's an acoustic wave, it's not a mechanical wave. So we don't have any effect on this. More questions? If more questions coming up within the next days or week, whatever, just write an email to EMS and you will get an answer. Okay. One more minute. Thank you for attending this webinar. Oh, more question, hang on. After 5 sessions, how long a break you give before giving another 5? It's depending on the issue. Basically, if you're talking about heel spur and all this stuff, 3 to 5 sessions can be enough already. I always tell my patients we wait another 3 to 4 weeks because of the healing process needs to start. And we know that the last shockwave lasts 3 to 4 weeks. So I always suggest to wait 4 weeks, checking whether it's good or whether we need one more or some more treatments, and then I continue with another 5, 3, whatever is needed. So a 3 to 4 week break in between is a good advice. How do I know that the tendon is more than 50% torn? Yes, that's a really, really good question. So you have 2 ways, basically, using diagnostic ultrasound, check the MRI picture. If you have good MRI pictures, it's written sometimes how much is torn. If you're not sure about how much is torn, you need to feel strong enough to do it, or just say, I stay away from it. This is something about talking to your patient. I don't know how much of your tendon basically is torn. We can try it. It feels good for me to try it, but he needs to sign it. So to be sure, you don't do it. Otherwise, talk to your patient and let him sign. Are there any online demonstrations of frozen shoulder shockwave treatments? As far as I know, there are not. We are just planning to do some lectures like this with live treatments. The problem is every frozen shoulder, not just every indication is different. So every patient is different. Yeah, we've got frozen shoulders where extra rotation is more problem, abduction is more problem, extension is more problem, inner rotation, whatever. So not all of these frozen shoulders are behaving the same. So we are always concentrating on the most painful areas in the very beginning, checking the range of motion, mobility of the shoulder, concentrating on the whole capsular area. So from the front, the whole shoulder area, also going down a bit more in this area. Sometimes it's necessary to treat this area here. Yeah. So it's depending on what issue has your patient basically has. If you have a specific patient in mind, give it a try, and then if there are any problems, then just text me. Yeah, and then we can discuss about this patient. That's what I mean with network. Every patient's they are all so specific. Yeah, and sometimes it's not working, and then we need to talk about. Yeah, and it's easy to talk about. And as many people we are in the group, the more you have to talk about, to talk with. You're welcome, Michelle. Great, Chris. Enjoy, and you will see it's such a great success with what you can achieve with your patient. Great. I think there will more questions will come within the next time. The webinar has been recorded, so it will be available for you to just have another look at it. And then, yeah, when there are questions, we talk. Have a great evening all together. Thank you for joining. Yeah, we keep you updated about our next things we are planning. Probably some live demonstration videos, some real patients, yeah, just to make it a bit more exciting. And then, yeah, we keep you updated and stay healthy and enjoy using the shockwave. See you. Bye-bye.